Welcome to our virtual guest speaker. We have with us today Jane McClelland. She currently works as a quality payer analyst for King's Daughters Medical Center. She's had a very long history with the hospital and has worked in a lot of different roles. Prior, she's been a practice manager for several practices, including an urgent care and a pediatrics office. So we will get a lot of great information from Jane today. If you have any specific questions that you would like to ask, if you guys want to pop into the chat and send those to me, I will be monitoring. So with that said, we'll go ahead and get started with our guest. Jane, how are you doing today?
I'm doing great. I'm looking out the window to a pretty sunshiny day.
And it's so nice, but we still have some of those, even though it'll get pitch dark at like 5:30.
I know, but I guess it's time for us to let go.
Yes, we have to endure to appreciate the summer and spring. So, well, first I might ask you, what is your role as a quality payer analyst? What does that job entail?
It's a new department, so it's not a new program. It's been in existence maybe about 5 years, but it's a new department that the medical center has created to put some focus on. It's kind of incentives that we get from the insurance companies in our mission to keep people healthy. And people think, well, why would a hospital want to keep people healthy? Well, healthy and compliant patients have better outcomes, and they have a better quality of life, which leads to the health in our community. And I'm sure, I don't know exactly how many is out there in telephone land, but you might have a family member or know someone who might have a chronic illness, and they just don't follow the provider's instructions all the time. They may not get their blood work on time, and they may think, oh, that's no big deal. But, when you do go to the provider's office, and whether you see a doctor or a nurse prac or whatever, a lot of that testing that we do can offset and make a lot of the chronic conditions a lot easier to deal with. And some of you may deal with a chronic illness because diabetes is something that's very prevalent in this area.
Mm-hmm.
So it may be an invisible disease. It may not look like someone's sick, but it could be doing damage to your organs if you're not taking care of yourself. So I think it's more of, we harp at people, get your screenings, get your colon, get this, get that, but ultimately it is for a better quality of life. So I know that was pretty long-winded, but it's more than just, okay, we're a hospital here, and if they need us, they'll come.
You have to be a little more proactive.
Yes. And again, it's an inconvenience. Anyone going in the medical field, you're going into a field where people do not want to use your services.
Mm.
So class, think about it that way. Sometimes it can be frustrating, but it's helping people. Not everybody knows the science behind stuff. We saw that a lot with COVID, and people not realizing the dangerous and seriousness of the issue. But there are some reasons that you have to have your finger stuck maybe every month or every day to check your blood sugars. So, but even if you're non-clinical and you decide not to go into the clinical aspect, don't hesitate to think of a hospital or any kind of freestanding medical clinic, because there's always something there that can be a non-clinical function. You may be someone behind the scenes that is doing a lot of work to help the people on the front lines taking care of patients. Think about computer issues and security issues now. We get emails weekly from our IT department saying, don't fall for people. This is phishing. That's a spam. Just be careful. And it's not just your medical safety. It's the safety of your medical information. So don't hesitate to think of a hospital, even if you don't want to go the clinical path.
That is a great point, and a lot of what we do in the administrative role does support patient outcomes. I don't think we realize that enough, but
That's true.
yes, even if you're working the phones, check-in, whatever, you're definitely tying into patient having a good outcome, hopefully, and being treated with their ailment. My next question would be, what is your typical day like as a quality payer analyst? Does it vary
Well,
day by day?
it can, and we have certain things like we deal with 9 major payers and insurance companies. So we get a scorecard from them, with like
Mm,
we take care of 12,000 of their members,
mm,
and this percentage of their members haven't had their mammograms this year. They're within an age range. So we would go into their portal and download reports and work the list and try to make phone calls or remind people. We get a lot of, oh gosh, I can't believe that's due already, or I was just thinking about it, or no, I don't want to have that. So it's a lot of reaching out and letting people know. Also, one of the things we started, actually it was earlier this year, is sending a my chart message. I think most
mm.
everyone would be familiar with kind of the electronic part
Yes.
of your medical record that you have access to. And we would send a birthday message and say, your birthday's coming up. These are some of the screenings. Let's get that done during your birthday month. So it's been interesting that people have, called back in and said, oh, thank you for the reminder.
Mm.
Or along the lines of, I'm not interested. So it's whatever preference, we just kind of go along with whatever they are feeling today. Some people have chronic illnesses and they are just worn out with going to all the specialists. And you have to be very empathetic because you're calling a list from a spreadsheet and those may not seem like people to you.
Yeah.
But when you actually connect with them on the telephone, you hear the stories. You've got, I don't have transportation. My car just broke down.
Mm.
I need help getting to and from my appointments. So it's more of those in what payers are really calling the social determinants of health.
Yes.
I've got a barrier in getting my health care. And that's what a lot of the things that our care managers do in our department that work out in the clinics. So making sure that someone with a new broken hip is going to be able to get their meals. So, we can set them up to have, and a lot of insurances do pay for meal delivery while someone is convalescing. There's a lot of benefits that people really don't know about. And they might get a packet from their insurance company, but they haven't read all the well, I'll put that up and I'll read it later. Well, they have a lot of incentives for their members to take advantage of screenings.
So
Yeah,
you spend a lot of time calling patients
we do.
and
We do
the
the outbound and inbound calls.
so they might call you back.
Yes,
Do you have staff or personnel that does just that, the phone calls?
we do. We have 9, they're called wellness facilitators. And our main focus is really trying to get just their at least an annual care visit once a year. And then they can address what the companies call care gaps. So a care gap might be a gap in care that women between the ages of 50 to 75 need a mammogram or a colonoscopy. They're on a medication that they need to make sure that they don't miss any. And they can miss because they don't have transportation. They don't, they may not know about a mail order service to make it easier to get your medicines. There's all kinds of programs to help with the cost of that. So it's more of reaching out and then kind of peeling the onion on each person to see what their barriers might be. So it's a long way from build a hospital and people's going to come there to these are the barriers that I have in my own health care.
And it is wonderful that those are being addressed. And I love that you mentioned the social determinants of health because That's just as big a factor as anything if you're coming in for treatment, which you gave some
Yes.
great examples for. And I know your role currently deals a lot with wellness and prevention. I'm curious as to what the most common types of screenings that you recommend for your clientele.
Well, the payers, of course, usually focus on like the big ticket items like a colonoscopy. You only need those once every 10 years.
Mm.
But then there's some other options that, like you might have seen some of the ads for Cologuard. It's a kit that comes to your home, and you can do it in the privacy of your own home,
Wow.
and you return it back to the company. So all you have to do with that is say you are interested in a screening. So you don't have to go, of course, the colonoscopy is the gold standard, but you don't have to go that route if you're just unsure about it, or you may have some other issues that stomach, or some other issues that would complicate the whole process. Of course, mammograms, but then the diabetic has a lot of making sure they get an annual eye exam to make sure they don't have diabetic retinopathy. And so that is a hassle, I want to say, because then they've got another doctor to go to once a year to make sure that that care gap is met, that their eyes are okay, because diabetes really affects your eyesight. So they may be so into checking their blood sugars daily that they're like, oh, I just can't go to another doctor and, put out the expense in that. So there's just a lot to manage with a chronic illness, and just to keep healthy I say it's hard to do maintenance on your body the older you get. There's a lot of maintenance from head to toe.
Now, as far as insurances, do they cover the entire cost of the preventive exams, or does it vary?
Most of them do. Some, like Anthem would have, they're called lines of business. So they've got commercial, they've got Medicare and Medicaid. So we not only deal with Anthem, but we deal with all three of their plans. So they would have a different focus with each population of patients. Of course, some of your Medicare, they have abbreviations. You think medical terminology. These insurance companies have so many abbreviations. DSMP, it's like dual eligible members that would have both Medicare and Medicaid. So they've got extremely well coverage that just about everything would be covered. And then they offer incentives like a mother with, if she would take her children to their well child appointments, you're going to get a gift card for that if it's a Medicaid plan. Some of them will also pay for entry fee for Boy Scouts. They will pay for laptops. I mean, it's amazing the incentives that payers have to keep people healthy because it benefits them.
So I love hearing that. I haven't really heard examples of all these perks that you can get for staying healthy, but I can imagine why, especially an insurance company, would want to make that investment because it saves them money later on down the road, and it's just good for the patient overall. So now I'm curious because you mentioned you work with so many different payers, and a little bit about the electronic process. Do you use very many different portals in your job as far as accessing information on patients or going to insurance websites?
We do. We've got a portal on each of them that we would go in, and we would check. We get, like I said earlier, a scorecard. So they kind of give us an overview. Okay, we've got this many gaps, so let's work on that. And October, of course, was a big push with mammograms and breast cancer and all that. And then March is the focus on colon cancer. So all throughout the year, there might be a campaign that we would focus more on. What we're really coming down to at the end of the year is most insurance companies do their on a calendar year. So we've got until like 12/31 to make sure that we've got all the A1Cs for all the diabetics entered, the numbers entered for the year. So we help them with their data. They help us with data too. We do a lot of getting it out of the electronic medical record in a format that we can send to them.
Very good. Do you get in those portals daily, do you think?
Yeah, at least daily. There's a third party, it's called Optum, and they handle some of the, we just call it an Optum form. And what they do is, actually, I'll send you some examples.
Yes.
Of what the insurance offer that you can share with everyone. And then I'll send you an example of a form that would have, like, when the patient has a well visit with their provider, these are the things that we can address from a health maintenance standpoint. So it's a form that they provide that helps guide us, because the patient may come in for their annual wellness, but then they may, oh, well, I've been having hip pain, and we may go off on a tangent, but this form really kind of directs the appointment with the patient to make sure we get stuff addressed. So we kind of help each other.
So does your department have specific goals for a certain amount of time, like you get so many patients with this type of screening, or?
Yeah, we have goals, especially with the Kentucky Medicaid program, and that is all done and set through CMS, Centers for Medicare and Medicaid. So we get some funding back for helping them address and close gaps. What they do is, like, they'll have one of their members attributed to a patient, maybe Dr. Smith at Catlettsburg. And when they come in to see Dr. Smith, they've got a specific kind of pathway that, based on this patient's history, that we would help address and help try to keep them healthy. Now, a lot of people really like to go to the ER, which I don't know if anybody's really ever had an ER experience. You really only want to go there if it's an emergent situation.
Yes.
Just because of the weight, your exposure, you know, even if you can do a decreased level of care at the urgent care, or if it can wait until you can see your PCP. But some people like that on-demand appointment that I tell you, you're going to pay for it if you go to the ER with something that is not, you know, emergency, something along those lines. But a lot of people like that. And sadly, we've got some members of the payers who kind of use that as a social event, and they're lonely. And, you know, we try to introduce them to some programs, but there's no, you know, makeup for social interaction or, you know, some kind of communication. So lonely people really have some issues that are really hard to deal with. It's a sad situation. Hate to be a downer on a pretty afternoon, but it's out there, and we need to be empathetic, because you never really know who you're talking to on the phone and the issues that they're dealing with.
That is such good facts that you're stating there that we always have to consider. Now,
we forget about it. Even if you're answering the phone at the hospital switchboard, you know, you could be talking to someone who's not having some very good thoughts. So you just never know.
Yes, empathy is always key in our role as administrative professionals. So I love that you reiterate that.
That's true.
Now, you've had a lot of experience managing practices with King's Daughters. I was wondering if you might just give a little overview about your prior experience and the types of practices that you did manage.
Sure. It was, it was about 3 years, and I had 3 pediatric clinics, 2 primary care, and then one that we opened that we kind of shared with urgent care, which that was a really good relationship, because people may come in for an urgent situation. I need stitches, I need whatever. Oh, we see that you don't have a primary care provider that you follow with. We've got one in the office, or here's a list that can help better manage you than just having to depend on urgent care. I mean, you know, you need blood pressure checked regularly. You just need those basic things that sometimes people don't think of, but that's a good situation to share a building, I guess. And a lot of our pediatric practices, you know, they have such I don't want to say odd hours, but what we would see is that after 3 o'clock in the afternoon, when we had school and before COVID, that it looked like the bus pulled up and people were just coming through the door with hordes of kids because they had gotten sick at school and they needed to see a provider in the evenings. So when you collect data, and we would collect data on, volumes and days of the week and everything, you can make your decisions based on that on when to staff. So think about it. We knew that Friday afternoons were going to be busy because maybe the parents wanted a kid to be seen before the weekend. And then Monday mornings would be busy because they might have gotten sick over the weekend. Mm. So it's funny how staffing, and when you think about it, when you think about time off, everybody needs their time off. But people like to take Mondays and Fridays off, and that was our busiest times. So in healthcare, you really have to kind of go with your data and, do staffing that way too. But it was fun. I mean, you could back when the buses were loading up kids at school, it's like, okay, here they come. I'm all sick. But that was about 3 years worth. And it was interesting because, there was reasons for no-shows, but that's hard. You kind of have to be on the fence with that because you don't want a provider sitting around idle when other patients could be seen. But then you've got people who no-show because they don't have transportation, or there's just so many issues that you have to be flexible. You just have to be flexible.
And I love that you mentioned that. We were talking about different types of medical office scheduling this morning for the office procedures class, and you make great points at Friday afternoon, Monday mornings, and that's prime time when people want off, and you can't always grant that or have that flexibility just depending on your practice. But what do you think was the hardest part of managing, let's say, a pediatrics practice?
Well, I'd always go back to staffing just because everybody says a nurse is a nurse. Well, it is. You come out a nurse, but then you kind of get your little pathway of, okay, my pediatric population is just little baby adults, but, you need to think of things differently. When they have respiratory issues, it's a little different and more severe than when an adult does. So it was really getting someone who wanted to be a pediatric nurse because they were either scared to death of that population or that's all they ever wanted to do. And you think about it, a lot of them were young nurses who themselves were having kids and then having the sickness issues. So staffing really got to be pretty difficult at times just because people were not interested in that. Mm. I think now we're doing a little bit of kind of like train your own, or not really train the trainer, but getting someone that doesn't want or doesn't mind to work maybe a weekend when we have a walk-in clinic. So scheduling and the specifics of it, because pediatrics is a specialty, of course, and it just comes back to staffing again too. People don't get sick Monday through Friday, 8 to 4:30.
Please schedule your sickness at a more convenient time.
That's true. If you want that, you need to go to a factory and work on an assembly line, I guess.
Well, you also have a good point, and from my experiences in management, staffing is always the hardest part. Yes. Getting coverage, keeping that coverage, and having to address issues like tardiness and that's always the not so fun parts, but it's very prevalent in a manager's role. So now I'd like to ask a little bit about data. And we cover different types of medical information uses, like national data banks and things like that. But what kind of data do you review as a quality payer analyst?
Really a lot of the scorecards that they give us. There's a government program called Shared Savings. So if we focus, like some of the payers we have contracts with that we try to do, close the health maintenance care gaps, and then those patients that are high risk, if we can really go above and beyond to help lower their risk score and, actually save the insurance company and us money by keeping patients that may not need to go to the ER. Because again, we do see sometimes they're worse after they are in the ER exposed to stuff. So we try to help with cost and quality and access to care. When you think about staffing, then you think of, and this is not a bash or anything, but you've got some providers who want to see patients at certain times of days and might only want to work 4 days a week, and that's not always optimal. So we have to make sure that we have access to care, because that's a big goal that a lot of the payers want to make sure that we have enough slots for their members.
Now,
at the time they want them. Yeah.
When you mentioned scorecards, what kind of items are scored on those?
Actually, I've got one from this morning.
All right. Fresh off the press.
It's fresh off the press. So we do like compliance on, I mentioned earlier, mammograms and colorectal cancer, but then, they set kind of a percentage goal, and then we would get a star rating. So we need to make sure that the members are attributed to one of our providers that we can provide the care. So if they select an external provider, we really don't have access, and that's the limitation of an EMR, is that we wouldn't really know if they're having their mammograms and stuff done at another facility, unless we would get a list from them, call the facility, maintain paper records, have that faxed to, it's kind of going back in time, have that faxed to us, let us scan it in the record, and then the provider can make the whole picture of how to deal with them. So it's not just data from the insurance company, it's tracking down medical records from other places. And one thing, our pediatric population, of course, that immunizations are, there's like, you have to have so many visits before you're 15 months, you have to have all the immunizations, and if they haven't had them here, we can't give the rest of the immunizations without knowing how many they've had and the records from another facility. So there is a statewide, state-by-state registry that their immunizations would be entered into if they're seen in another facility or another state. So that's a big undertaking by the whole state Medicaid, Medicare department, is to make sure that those are tracked in a database. So you can imagine every kid having to have their immunization logged somewhere. And then you've got kids that, have their names changed and adopted and fostered, and it's really, it's so heart fulfilling when you see someone come in, that a caregiver that has a foster child, that they might have gotten that kid at 6 o'clock the night before, and they give them a binder, and they have to see a provider within like 12 hours of getting the child.
Gosh.
So then you have, if they're 1 day old, that's a little bit easier because they, had hospital stuff. But, if they're 6 months old, you might not know if they've had any immunization. So we do a lot of hunt and search and investigate and calling, tracking down stuff, just to complete an appointment.
Now, I will take a quick break and ask the students if you have any questions, go ahead and get those in the chat for me. Just wanted to do a check-in. Now, continuing on with data review, was it very different when you were a practice manager, or what types of data did you work with in those roles?
Well, we did a lot of like internal work for the clinic. So I would collect data like on no-shows or times a day, things that we can make decisions with our processes. Other data data was just how many annual well visits, and to see if, we can make sure, reach out to our patients and, help call and say, you haven't had an appointment in 2 years, let's get you back in. We've got a lot of things. We're working with your insurance company to help get addressed. How are you feeling today? What do you need? What roadblocks would be had? But more, it was just collecting your data and looking to see how you can improve your processes. And there's stuff like if a patient had lab work done and they had a value that was out of range, that's called a critical lab value. So the lab, would call. We need to make sure that a nurse took the call and they were assessing that, and they let the provider know within 15 minutes that the patient had a critical lab result.
Oh, wow.
So there's a lot of guidelines that we had to meet and follow. And when something like that would come in, it's like everybody drops what they're doing and goes and finds either the provider, tries to get a hold of the patient. They might need to go to the ER right then for an IV. They might need to go be seen somewhere immediately. So it's kind of like, even though you've got patients there, for your critical, you have to kind of drop what you're doing. And then again, that's where flexibility comes in. I need you to take over. I need you to do this. I need this done. And that can really wake you up on an afternoon when you need a cup of coffee.
Make that a
we've
double.
got a potassium of 2.0, and that's life-threatening, so we need to get something done about it. And when that usually happens, on a Friday afternoon or, late in the day.
Yeah. So my next question is about telehealth, and you mentioned something that was really interesting, and I didn't realize you have an at-home option for a colonoscopy now. So I'm just curious about how telehealth is currently impacting your job in the hospital overall.
Well, I tell you, as you know, COVID changed everybody's world, and telehealth had always been an issue, and of course, insurance companies did not want to, I guess ultimately comes down to pay for that, because, you take out some of the regulations when it's not on site. But it's funny because I remember March 15th in 2020, we got a phone call that we were going to change all of our visits to telehealth. So it was like, oh my goodness. Also, all the providers had to have like an app on their personal phone. And then they had to set up, some of the secure guidelines and stuff that they could be at home to do telehealth. But I don't think we will ever get back 100% going away from telehealth, because it was so convenient for elderly patients, those with transportation issues, again, mobility issues. If you have someone from a nursing home, it is just so stressful and hard on them to get them into an office on a stretcher.
Yes.
So if the provider can essentially provide care at their home, that was a beautiful thing. And even with the phones on people's iPhones, they could hold it up, and the provider could do not a hands-on assessment, but you can see if someone's eyes or elbow or whatever's swollen. So you can do a lot that is very helpful and way better than not having an exam like that. But I do think telehealth is here to stay. And probably a lot of different, people's going to be more creative in what they do with it.
I hope it's here to stay as well. Because when you mentioned going in on a stretcher, I have an elderly relative I care for, and she's in nursing home, and we don't want to have to make her go somewhere like that. Yeah.
It's just so stressful on them, and the exposure. I'll tell you, one of the best things that we actually did, we threw together that drive-through lab. And I'm telling you, they put that building up in the winter in 2 months. It was an undertaking that was massive. But my mom uses it because she doesn't, she can't, her mobility, she can't go into the hospital as many times as she needs blood work. And, find a lab and park and all of that. So, mean, you can get your flu shot through the drive-through, your COVID booster. It's just been an amazing thing.
Is the drive-through still working?
Yes.
Okay, I was hoping to hear that.
Actually, our numbers, that's some other data that we collected, has been through the roof with this flu surge and then RSV and, a lot of just getting blood work and stuff like that done. And then we're starting a $100 million construction project at the hospital, which is going to be so painful until it gets done. And the more that we can keep patients, away from main campus for stuff like that, that's just going to be that much more helpful.
So you have given us some wonderful insight on a lot of different types of positions that you've done at the hospital. And I just have one last question I want to ask you, and this is pertaining to job interviews. When you interview a candidate, what types of questions would you ask, and what kinds of responses are the best, do you think?
This is funny because it's like every interview is different, but still when you think, you really don't need like set questions, and people, Google it and they're going to ask me this, and I think the one response that I don't want to roll my eyes, but I want to say, come on, is when somebody says, I'm a people person. And I'm sure most everybody, besides those really big time introverts, are people persons, but sometimes people can get on your nerves.
Yes.
And it's okay to say, this is how I deal with it, or this is what I do, but just really in an interview, being genuine, let the interviewer know that you know a little bit about the company. You may not know about the job you're interviewing for, but you talk about your strengths and then give an example on how you can prove it. And again, I've said it 3 times, flexibility. And if you are offered something that you may not think, oh, that sounds gross, I don't want to do it. Get the experience. If there's something that, like I worked in security when I first came. I was an HR clerk for like 3 months, and then I went to security. I never thought I would work. I typed up reports, and I would be on the radio, and that was an interesting part, I just call it, of my development, because you got to meet people and hear their stories and try to work out things. Okay, well, let me see if I can make a phone call for you. So never turn down anything, even though it may sound gross, but there's always an opportunity in something.
You got to get that experience somehow.
You do,
and
again, you don't have to be clinical to work at a hospital. I mean, if you like working with computers and networking, that's the way to go, because it's just going to get more in depth and the security of it. I mean, like I say, we get an email from David every week, and it's like, he has us scared to death to click on anything. So he's doing his job very well by scaring us to death.
We get those emails here at the college, and I got one over the weekend that was from the secretary in the president's office, or it was presented as her, and it about made me have a heart attack. And I looked at the email, and it was a Gmail account. So I was like, okay, that's not real. But oh my gosh, it really fooled me.
Yes, if people would use their powers for good, you wouldn't have to worry about that.
Well, they were definitely effective with that one. So, well, Jane, you've given us some great information. We appreciate you spending some time with us. I know you'll be doing some mock interviews for some of our students coming up, and we're excited for them to get to learn from you. And you're just really positive, and it's just great working with you in the program, and for you to spend time with the students, giving them insight into the depth of your experience, which you have a lot to offer. So,
well, I just really think it's a great cooperation, for students to come and see what it is, because, I hear a lot of people say, I don't like to see blood. I'm like, believe me, you don't have to.
Yes, thank you.
There's a lot of things, and you can make a great career, and and I can get talking on it, and but there's a lot of great people who really want to help patients and families, and we have to work together in the community.
Absolutely. Well, we enjoy our partnership with ACTC and King's Daughters, and appreciate you spending your time with us again this afternoon. So at this point, I am going to stop the recording.